Hello and welcome to my channel. This is the lecture about to continue our talk about the hand. We will study the muscles of the hand. So let's begin. The muscles of the hand divided into, those four pollics. There are four in number. Three for the little finger. Palmaris brevis muscle, which is a superficial muscle that wrinkles the skin, and the lumbricals and interosseii. For the thumb, or what's so-called the thenar eminence muscles, there's abductor pollices brevis, from the flexor retinaculum and trapezium to the radial side of the proximal phalanx. It abducts the thumb at right angle to the palm, as we described the movements of the palm of the thumb in the last lecture. The flexor pollicis brevis muscle from flexor retinaculum and trapezoid to radial side of proximal phalanx with a sesamoid bone in it, okay? The flexor pollicis brevis muscle. It flexes the thumb. Opponens pollicis from the flexor retinaculum and trapezium, it's deep, it's hidden underneath the abductor and the flexor. This is the opponens pollicis. You must remove the abductor pollicis to see it. It also doesn't reach the phalanges. It goes to the metacarpals. It's attached to the flexor retinaculum and trapezium. It goes to the, it goes to the lateral half of palmar surface of the first metacarpal. It's for opposition movement, to bring the pad of the thumb finger to against the pads of the other fingers, pad to pad. The adductor pollicis, the one you see here, has two heads: oblique head from the bases of second and third metacarpals, transverse head from the distal 2/3 of the shaft of the third metacarpal. This is the transverse head. Inserts in the ulnar side of the proximal phalanx of thumb with a sesamoid bone in its tendon. The action adducts the thumb. Hypothenar muscles. The palmaris brevis muscle, you don't see it here because it's in the skin. It's subcutaneous from palmar aponeurosis and flexor retinaculum to the dermis of skin. It's superficial to the ulnar nerve and vessels. It wrinkles the skin for a better palmar grip. You can see the wrinkles on your palm of the hand. The abductor digiti minimi. This is the abductor digiti minimi muscle from the pisiform and pisohamate ligament to the ulnar side of the proximal phalanx of the little finger. It abducts the little finger. The flexor digiti minimi from the flexor retinaculum and hamate hook to the ulnar side, be careful with that, to the ulnar side of the proximal phalanx. Deep branches of ulnar nerve and vessels pass between it and the abductor digiti minimi. There's also the opponens digiti minimi, which is deep to the abductor digiti minimi from the hamate hook and flexor retinaculum to the palmar aspect of shaft of the fifth metacarpal bone. It's for opposition movement, but it's not as as efficient as the one for the thumb, because the thumb has free mobility. Now the lumbricals, they arise from the tendons of the flexor digitorum profundus. The first and second lumbricals are unipinnate and arise from the radial side of the flexor digitorum profundus, as you can see here. The third and fourth lumbricals from the adjacent sides of tendons of the flexor digitorum profundus. They attach to they pass anterior to the metacarpophalangeal joints, so they flex them. The metacarpophalangeal joints. Attached to the extensor expansion, so they extend the interphalangeal joints, as in writing position. Okay? As in writing position. They flex the metacarpophalangeal joints and extends the interphalangeal joint. The interossei muscles, they are divided into palmar and dorsal interossei. The palmar please pay attention to this because this will give you a hint about their attachments. The palmar interossei adduct fingers. They are unipinnate, so they can be seen from can be seen only from the palmar aspect, because the dorsal interossei are bipinnate, so they obstruct the view from the dorsal aspect. The dorsal interossei abduct fingers, and by abduction and adduction we means towards or away from the middle finger. So the palmar adduct and the dorsal abduct the fingers, okay? There are perforating arterial branches, just like the foot, proximal and distal perforating branches between the metacarpal branches on the dorsal surface to the metacarpal branches on the palmar surface through the interossei. Okay, now to figure out the attachments of the palmar interossei, we said the palmar adduct. So we do not need to put lumbricals for fingers that have adductor muscle. So the thumb, no need for that because it has an adductor pollices, right? So we need one for the index finger. On which side? On the ulnar side, to pull it towards the middle finger. The middle finger, we don't need any lumbricals because it cannot be adducted on itself. Okay? And actually, the only adduction movement occurs at the middle finger. It's when it's abducted and the other abductor is pulling it back. You will see that. On the ring finger, we need it on the radial side to pull it towards the middle finger. The same apply for the little finger. So we have three lumbricals, 3 palmar interossei for the index and for the ring and for the little fingers. But the dorsal interossei, on the other hand, they are bipinnate to the adjacent bones. Now, how to attach them? The dorsal abduct. Okay, we do not need one for the thumb because it has its own abductor. We do not need one for the little finger because it has its own abductor. Okay, what about for the index finger? Attach it on the radial side to pull it away from the middle finger. What about the middle finger? You need 2 because movement in this direction is abduction and movements in this direction is abduction. So actually the abductors or the dorsal interossei perform the abduction, and at the same time the other one performs the adduction to the original position. Got that? So it does not need palmar interosseous muscle. What about for the index finger? We need one on the radial side to pull it away from the middle finger. That's why we have 4 dorsal interossei. Okay. For the vessels, we have the ulnar artery and the superficial palmar arch. This is the ulnar artery, of course, the superficial palmar arch. Between Palmaris, brevis, and flexor retinaculum, lateral to the ulnar nerve and pisiform, the ulnar artery. It then forms the superficial palmar arch. The arch deep to the palmar aponeurosis and superficial to the flexor tendons, and the arch communicates with the palmar arch of the radial artery. The deep palmar arch, on the other hand, is from the radial artery, arises from the medial aspect of the radial artery, just medial to the the deep palmar arch, the deep palmar branch that completes the deep palmar arch from the ulnar artery arises from the medial aspect of the artery, just medial to the pisiform. Branches of the superficial palmar arch are the palmar digital branches, okay, and 3 common palmar digital branches. Common palmar digital because they will receive the palmar digital branches of the deep palmar arch as well. So we have palmar digital branches called from the superficial arch called the common palmar digital branches. Why common? Because they will receive the palmar digital branches of the deep palmar arch, okay, and together form one artery that will split to give the digital branches to the adjacent sides of the fingers. The radial artery and the deep palmar arch. The radial artery curves around the lateral side of the wrist, and it can be felt in the floor of the anatomical snuff box. Then penetrates anteriorly, goes anteriorly. First, it pierces the first dorsal interosseous, becomes between the first dorsal interosseous and the adductor pollices, and then emerges on the ventral aspect or the palmar aspect as the deep palmar arch. The deep palmar arch gives palmar metacarpal arteries that will join the common palmar digital branches, and gives perforating branches pass posterior between the heads of the origin of dorsal interossei to communicate with the dorsal metacarpal arteries. Okay, now the radial and ulnar, before they go to the hand, before penetrating, they give the carpal arches that will supply the carpal bones, okay, and the artery also, the radial artery gives the first dorsal interosseous on the dorsum before penetrating. Now, between the first dorsal interosseous and adductor pollices, it gives the princeps pollices to cover the thumb, and radialis indicis artery to cover the radial side of the index finger. There is a test called the Allen's test where you can determine the dominant artery that supplies the hand by applying pressure to both arteries at the same time, the radial and the ulnar arteries of the patient, and then release one by one and see the rate of filling of the hand with blood. This determines the dominant artery, either the radial artery or the ulnar artery. This is called the Allen's test. Veins we have on the lateral side, the cephalic vein that originates from the lateral side of the dorsal venous arch. It passes over the roof of the anatomical snuff, in the roof of the anatomical snuff box. The basilic vein on the medial side of the dorsal venous arch, and it receives, a median vein of forearm drains superficial palmar venous plexus. And deep veins, the venae committantes to the arteries, start by, superficial and deep palmar venous arches that accompany the superficial and deep palmar arterial arches of the radial and ulnar. Lymphatics with the veins. On the lateral side, they go along the cephalic vein to the axillary lymph nodes. And on the medial side, they go to the supratrochlear lymph nodes first, on the medial side, and then to the axillary lymph nodes. The nerves that supply the hand, the median nerve gives the anterior interosseous, as we discussed before, proximal to pronator teres, ends by supplying the carpal region, the anterior interosseous, deep to pronator quadratus muscle. The median nerve gives palmar cutaneous branch proximal to the flexor retinaculum. In the hand, it gives a recurrent branch along the, crosses the crease for the thenar eminence. Recurrent branch to supply the thenar eminence muscles, then gives lateral and medial branches. The lateral branch to the thumb and radial side of the index supplies the first lumbrical, and the medial branch to the index, middle, and ring fingers, and supplies the distal dorsal parts also, the nail beds. It extends its supply dorsally to the nail beds, and this you must keep in consideration when testing for on the dorsum side of the hand, for example, for the radial nerve. Do not test the dorsum of the finger distally, because this is supplied by the median nerve. You go proximal, and the safest way to test for the radial is at the base of the thumb, at the dorsum of the hand. Okay, the lesion of the median nerve gives what's so-called the ape hand, with the thinner muscle wasting and loss of sensations on the lateral 3.5 fingers. The ulnar nerve gives palmar cutaneous branch in the middle of forearm and dorsal cutaneous branch before the wrist joint. It divides into superficial branch that supplies the Palmaris brevis, then ring and little fingers, and the deep branch passes between the abductor digiti minimi and flexor digiti minimi in the concavity of the deep palmar arch artery. So what's in the concavity of the deep palmar arch is the deep branch of the ulnar nerve. Don't forget that. The radial nerve has a superficial branch to the dorsum of hand, and the deep branch between the superficial and deep extensors. It forms a pseudoganglion and supplies the carpal region, bones and articulations. Now this is just a schematic of the ulnar nerve and the radial nerve and the median nerve. See, the ulnar nerve covers the medial 1.5 fingers, and the median nerve covers the rest of the fingers on the palmar side. On the dorsal side it's the same, but here on the dorsum side is covered by the radial nerve. Okay. Now this is a recollection of the segmental supply of the muscles. C3 and 4 for the trapezius and levator scapulae. The C5 for the deltoid and supra and infraspinatus muscles and the biceps. The C6 for pectoralis, latissimus, brachialis, and brachioradialis. C7 for the superficial flexors and extensors. C8 for deep flexors and extensors, and T1 for the muscles of the hand. This is the segmental nerve supply when you test for the movements of muscles. Now, there's also sympathetic supply from T2 to T5 in the spinal cord along the sympathetic chain Gray rami communicantis, and when this affected, it produces what's so-called the Raynaud's disease, in which, in nervous tension or in cold, the blood cannot, there is a vasoconstriction of the superficial vessels, so the blood cannot, go superficially to the skin, as you can see here. This is the Raynaud's phenomenon, or Raynaud's disease. Last, the reflexes. The biceps reflex is centered in C5. The brachioradialis reflex is centered in C6. The triceps reflex is centered at C7. The dermatomes, as you can see here, lateral arm, forearm, and thumb is for C6. The palm, middle of the palm and fingers, and middle 3 fingers is C7. C8 is for the little finger and the medial hand and the medial forearm. T1 is the medial arm and axilla. Now there was a question in the USMLE exam before asking T1 and T2 are adjacent to each other. This is right. T1 because it's applied, it's on the medial side of the arm, and T2 is on the chest. So they are adjacent to or facing each other. Okay, T2 on the chest wall. Well, this concludes our talk about the hand and the upper limb. I hope you got the maximum benefit from this lecture, and thank you very much for watching.